Good morning. We would like to welcome and thank you for being here. We are happy and grateful that you are able to attend this important conference live. The IKCS Planning Committee has put together a very dynamic program with some highly profiled expert speakers, and we are delighted to share their knowledge with you over the next few days. Thank you to the IKCS Planning Committee and the KCS staff for their hard work planning and putting this event together. I would like to remind you that there are still some tours available. Go to registration desk and see where you can pop on one of these tours and to go and see this exciting city and very historic city of Edinburgh and continue networking. We would like to encourage you to share pictures and also have the conversation on the social media, then use the meeting hashtags IKCEU23. I would like to thank the premier sponsors, MSD, and also the elite sponsors, Bristol Myers Squibb and Excelsis, and our contributing sponsors, Pfizer and Eisai, for their support for this event. Please go and visit them in the showtime and also in the breaks. There are some posters in the exhibit hall. We encourage you to look at them and talk with the authors and then have a conversation and also do the networking there. Please close your mobile so that you don't disturb the person next to you during the session. And we will start with the first session, Challenges in Surgical Decision-Making. So I will chair this session along with Professor Bradley Leibowitz. He is a highly well-known researcher and doctor in the Mayo Clinic. He has been a director and chair since 2001, has published more than 300 papers among a lot of renal cancer, and I've heard he is a fantastic mentor to his staff, including residents and especially the fellows. So please, Brad, can you continue?
Thanks, Lars. It's an absolute pleasure to be here. Apologies for starting 5 minutes late, but we had such great interest in a surgical session that we had to make sure everybody had an opportunity to filter into the room. As a urologic oncologist, it is wonderful to see all of you interested in the challenges of surgical decision-making in kidney cancer. As the chair of the board of the KCA, it is just an honor to be able to be here, and I wanted to extend my gratitude to all of you for attending the meeting. I also would like to extend my gratitude to the planning committee, as Lars said, and to the KCA staff for all of their hard work in getting this wonderful meeting set up. So I'm just going to very briefly introduce this topic. As we all know, imaging is used for everything nowadays, and because we do so much imaging, we are frequently finding renal masses and often finding incidental, completely asymptomatic small renal masses, many of which are benign. Many of those that are not benign are very indolent varieties of renal cell carcinoma, and we don't have great predictive information to guide our treatment for these patients. And we have an increasing repertoire of options for managing these patients, including now wonderful data indicating that we can do surveillance, phenomenal data on the outcomes with ablative approaches, and obviously we have multiple surgical options available to us. If you pile on top of that, as a challenge for the surgeon, the possibility of neoadjuvant or adjuvant therapy and how that may impact our decision-making, and broad confusion about what is the role of cytoreduction today in the management of patients with metastatic disease. And it makes it obvious that this session is going to be very valuable in helping us understand the landscape for surgeons in renal cell carcinoma management today. So this is the session. I'm really looking forward to it. We'll introduce the speakers as they come up in order. The first speaker is going to be Dr. Sarah Suka, and Sarah's going to talk to us about treatment options for clinical T1A renal masses. She's going to start the ball rolling with surveillance versus active therapy. Sarah?
Well, good morning, everyone. It's an absolute honor to be here, and I'd like to thank the KCA for the invitation to present to you today. In the next few minutes, I'd like to introduce the concept of active surveillance, and I want to talk a little bit about the basic tenets that underpin the validity of this as a management strategy for small renal masses, get into the nuts and bolts of how we do it, and then talk a little bit about where it sits now in the guidelines and what we need to do in the future. So let's get into the why. We know that the incidence of kidney cancer is increasing worldwide, but kidney cancer mortality rates are going down. This is largely thought to be due to the fact, just as Dr. Leibovich posited, that as we surveil patients more with the ubiquity of cross-sectional imaging that's widely available, especially in developed countries, we're picking up more of these asymptomatic small masses. But we know a couple of key facts about small renal masses from a body of literature that's been developed about the natural history of these masses over the past couple of years. First of all, a number of these masses are not cancer at all, and especially among the very small masses, that rate can be up to 30 to 40%. However, small renal masses are histologically heterogeneous and can represent any of the number of histologic tumors that we can find in kidney cortical masses. But as masses are smaller, there's a higher likelihood that they're going to be indolent or less aggressive. Importantly, small renal masses also grow slowly. From the DISARM registry, we know that they grow on average about 1 millimeter per year. And in fact, 80% either don't grow or they grow less than 5 millimeters a year, with only 1 in 5 growing more rapidly than that. And importantly, we know that growth reflects histology, such that the tumors that grow more quickly are more likely to harbor more aggressive histopathologies. So we now know that small renal masses have a low malignant potential. Thus, it's imperative that as surgeons, we think about how we can maximize or minimize the morbidity of overtreatment and avoid unnecessary surgery. Now, there are 3 necessary criteria that have to be met in order for active surveillance to be both acceptable and adoptable. It must be safe, delayed treatment must be safe, and it also has to preserve quality of life, and I want to get into those points next. So this is a large meta-analysis that demonstrates that with a median follow-up, or mean follow-up of about 55 months, the metastasis rate of patients with small renal masses less than 4 centimeters is about 1.8%, with cancer-specific mortality occurring in less than 1%. Now, importantly, almost 30% of that patient population died during the follow-up on these studies. And that's because overall survival among patients on active surveillance is overwhelmingly driven by the comorbidities and competing risks of death. On the converse side, cancer-specific mortality is incredibly low, at less than 1% among patients on carefully constructed and carried out active surveillance protocols, such as the protocol that's utilized by the DISARM registry. Metastatic events are rare, occurring in less than 2% at 5 to 7 years. Some masses don't grow, and if they don't grow, there's basically a 0% chance that that mass is going to metastasize. Now, the longer we follow these masses, though, more of them will grow. And from Fox Chase, we know that within about 5 years, up to 40% of patients will go on to therapy. Importantly, delayed intervention is safe and is not associated with an adverse rates of all-cause mortality. And again, there are low rates of cancer-specific death and metastasis. In the DISARM registry, the rates of progressing to definitive therapy over time was even lower, 12% over 5 years. Most patients who underwent definitive therapy in delayed fashion did so in about a year. And about half of the patients underwent therapy because their tumor was growing. Close to a half went to therapy because of patient progression, for patient preference. But importantly, in 90% of the patients who were treated, they preserved their ability to be treated with a nephron-sparing approach, and that's critical if we're going to posit that this is a safe approach. Finally, with respect to quality of life, we know that from data from MD Anderson and the Disarm Registry, quality of life is preserved. We do not identify an increase in illness uncertainty or mental health outcomes among patients on active surveillance over years on this type of protocol. So let's get into how we do this. Of course, the initial evaluation, the maximal linear tumor diameter, is measured on cross-sectional imaging. This can be done on either a CT scan or an MRI. Chest imaging is also done to stage the tumor at enrollment. However, we know from the Disarm Registry that routine chest imaging later on is not necessarily necessary. However, it should be done in cases where there is a cause. So for example, we identify an abnormality on baseline imaging, or there's new symptoms. After that, most active surveillance protocols will encourage routine surveillance at about 6-month intervals. I will say that I usually do an earlier initial touch point around 4 months, especially in patients who espouse some degree of illness uncertainty or decisional conflict around the selection of active surveillance. And we'll follow patients biannually for the first couple of years, and if there's stability, you can stretch that out to every year. I encourage utilization of non-radiation-based imaging, so either MRI or ultrasound. However, if you don't note if you can't characterize the mass on ultrasound, then you do have to use cross-sectional imaging. And then renal function is measured annually. Biopsies can be done at the outset if it helps a patient make the decision or for cause, for example, with growth as you're going through. And then in terms of the triggers for intervention, different authors have suggested that either a threshold diameter of 3 or 4 centimeters should trigger treatment, or the growth kinetics that are greater than, for example, 5 millimeters per year, which is what's used in the Disarm Registry, can trigger treatment. New histologic information, development of symptoms can certainly trigger therapy, and of course, patient preference is paramount. And importantly also, if a patient's health status changes and perhaps improves, it's important to consider that a patient may ultimately become a candidate for definitive therapy, and we have to pay attention to that and potentially offer therapy at an optimal time for that patient. And of course, decisions triggering therapy should always be made within the context of shared decision making, and nowadays, increasingly within the context of a multidisciplinary team. The tough question really is who we offer active surveillance to. And I would point you to this really wonderful article by Dr. Chandrasekhar, who really gave us a framework for thinking about the different factors that influence the treatment decision making. At the very base of all of this, though, we must elicit patient priorities. And what I often ask patients is, what is most important to you? What does a successful outcome look like for you? As Henry Marsh, who's a neurosurgeon from Britain, who's written a lot about challenges in decision-making and surgery, wrote in his most recent book, the problem is, of course, that a patient wants to know what's going to happen to him or her as an individual. And of course, we as physicians speak in terms of probabilities. But I do think that it's important to think about some personalized risk predictions when you're preparing for an active surveillance conversation. And so one thing I will often do is put a patient's numbers through a personalized risk calculator, for example, using the Lee-Schonberg index. And that's important because over time we know that masses tend to grow, which means that over time many patients will ultimately reach the threshold for needing to go through therapy. And for someone who's going to live a long time, active surveillance may not be a durable management strategy. We really need to weigh those short-term risks of cancer versus therapy against the long-term risks of cancer versus therapy. And to that end, along with many collaborators, and many of whom are in this room, we developed this risk prediction calculator that allows us to use personal patient-specific characteristics to generate treatment-specific risk predictions of cancer death, other cause mortality, and complications. And I often will use the ACS NISQIP risk calculator to help patients understand what their risk profile looks like should we undergo partial nephrectomy, whether it's favorable or unfavorable. So at this point, active surveillance has been taken up in the majority of the international guideline statements. However, overwhelmingly many of the guideline statements prioritize active surveillance among those patients who have a high burden of comorbidity and limited life expectancy, with the exception of the recent iteration of the AUA guidelines, which state that it's the optimal management strategy for masses less than 2 centimeters. But we know that active surveillance is underutilized, used by less than 20% of eligible patients in the United States in the early 2000s, for example. Importantly, this seems to be driven largely by how we counsel our patients, and a surgeon-level analysis demonstrated that that first 10 years of the 2000s, the vast majority of surgeons never utilized non-definitive intervention. Now, not all of these patients were on active surveillance. Some of the patients, of the 12% that did not get treated, many of them may have been on watchful waiting. But it's an important thing to think about, that how we talk to our patients about active surveillance really is important in terms of their decision making. And this was also highlighted in a recent study reporting patient-reported factors that influenced the selection of active surveillance. So wrapping up, here are a couple key take-home points. We've demonstrated that most small renal masses have a low malignant potential. Active surveillance can be helpful in minimizing the morbidity of overtreatment. And it meets the necessary criteria in that it is safe in the short term with respect to cancer death and metastasis-free survival. Delayed treatment is safe, not only from an oncologic perspective, but it preserves the ability to select nephron-sparing therapy down the line, and quality of life is preserved. So in terms of action items that I think we should think about in terms of how we can improve our successful utilization of active surveillance now and in the future, and improve its adoption in patients in whom it's appropriate, I think we do need to continue to refine and develop our personalized risk calculators to estimate those risks salient to our patient, or the patient that's sitting in front of you. We need to think about how we can integrate advanced and functional imaging and potentially artificial intelligence to better characterize these renal masses and their metastatic potential. I think we need to think about how we integrate biopsy into the utilization of active surveillance, and certainly some protocols rely on it more heavily than others. It would be helpful to develop predictive biomarkers that we can use as an adjunct to decision making. And ultimately, I do think we need to consider what progression looks like and those triggers for delayed intervention beyond simply size and growth. And so with that, I'd like to thank you for your attention today. I look forward to our discussion.
Thank you, Sarah. So next we're going to have Dr. Pernilla Sundquist talk to us about surgical options for T1A renal masses.
Good morning. Thank you for the opportunity to come to Edinburgh and talk about the surgical option for small renal cancers. The learning objectives for today is patient selection and counseling, which will be brief, and then surgical options for small renal masses or cancers, and then the surgical outcomes. EAU guidelines states that you should offer surgery to achieve cure in localized renal cell cancer, and offer partial nephrectomy to patients with T1 tumors. As the oncological results are excellent, it is of importance to preserve renal function and to lower morbidity in short and long term. But as many of the patients are in the 7th to 9th decades of life, often with other medical conditions as well, it is important to choose wisely for each individual patient. And you should take into consideration, of course, the patient factors, but also the characteristics of the tumor, the size, the location, renal score or Padua score, and you also have to take in consideration your own center's experience and available techniques. Age and comorbidities and frailty matters in patient selection. This slide shows the performance status of all Swedish RCC treatments for localized T1A disease the last 2 years. And as you can see, there is a selection bias where patients receiving renal resection, the light blue is COG0, you can see that patients receiving renal resections are healthier than the others. This might be good for the patients as they are receiving personalized care, but it is also one of the difficulties to recruit patients for RCTs. We are, as doctors, biased from the beginning. And hence, there will be I cannot refer to good RCTs in my talk today, but I will refer to other studies. So, the surgical techniques are nephrectomy or partial nephrectomy. They can all be done openly, laparoscopic, or robot-assisted laparoscopically. for small renal masses are not recommended, as it compromises renal function and is considered overtreatment. Nephron-sparing techniques lower the risk of cardiovascular events as well. Nevertheless, there are situations where nephrectomy is the only option due to tumor location or maybe due to a non-functioning kidney. There is also hand-assisted laparoscopic surgery. It is rare, but it seems to have as good outcomes as the other techniques. Single-port surgery has been described in feasibility studies only, and I will not refer to these techniques further on. So this leaves the partial nephrectomies and will be the focus for the rest of the speech. This slide shows the usage of different partial nephrectomy approaches developments during the last 20 years in Sweden. The Swedish National Kidney Cancer Register has a coverage of above 99%. And as you can see, there has been a development in favor for robotic surgery, and which might shorten the learning curves, but also raises costs. It has, however, some other benefits as well, and we will come back to that. And then how to do the surgery. When partial nephrectomy is the chosen treatment, further choices are to be made, but this is mainly by the surgeon. You can approach the kidney transperitoneally or retroperitoneally. And all three methods, laparoscopic, open, or robotic, can be used either way. The retroperitoneal approach might have advantages in posterior tumors, but it is less commonly used. And then about clamping. In open partial nephrectomy, bleeding can be reduced just by manual compression of the kidney, or if it's not possible, you can use clamping. In minimal invasive surgery, on the other hand, manual compression is not possible, but you can use clamping instead. There has been a long-going debate about on or off clamp during surgery for partial nephrectomies. But clamping does not seem to deteriorate renal function, but might instead reduce the risk of other complications. And both for the approaches and clamping on or off, the oncological results seems to be the same. And now, what about the resection techniques? A tumor can be excised with almost no margin, which is enucleation, or in between, enucleoresection, or you can use and have larger margins, which is resection. In a study by Professor Minervini and colleagues, the risk of positive surgical margins is highest with enucleoresection. The positive margins were 5% in enucleation, 10% in enucleoresection, and 2% in resection. The risk of acute renal injury is higher in enucleoresection and resection than enucleation. So it seems that you can actually have rather small margin, or otherwise larger margin. And then what about the surgical outcomes? The robot partial nephrectomy has a longer warm ischemia time, even though it's less than laparoscopic partial nephrectomy, less bleeding, shorter hospital stay. Open partial nephrectomy, on the other hand, has a less warm ischemia time, larger blood loss, more complications, shorter operating time, and a longer hospital stay. The surgery has good oncological outcomes regardless of the technique, just as you heard before, even if you don't do anything at all. But there are some benefits for the patients with minimal invasive surgery. And a surrogate for surgical quality is trifecta. And trifecta is achieved when absence of perioperative complications, there are no positive surgical margins, and the warm ischemia time is less than 25 minutes. These factors are affected by surgeon's experience, size of tumor, tumor location, and the resection technique. And after 1 year, pentafecta would be the goal, where renal function is preserved and there is no development of chronic kidney disease in addition to the trifecta criteria. Pentafecta is affected also by the size and location of the tumor, as well as the experience of the surgeon. But you can also see that the rate of chronic kidney disease was lower after robotic partial nephrectomy. And in follow-up, in the positive surgical margins, the TNM classification, size, nuclear grade, and histological tumor necrosis were independently associated with the abdominal recurrence in patients with clear cell carcinoma. And the same features, except for surgical margins, were significantly associated with distance recurrence. So there has been an ongoing debate about the effect of positive surgical margins, but it does seem to have an effect on local recurrence. So to wrap it up for you, the oncological results are excellent, regardless of the surgical technique. I think it's more important to avoid overtreatment and also to make sure to preserve renal function. Robot partial nephrectomy may benefit the patient in terms of less morbidity and shorter convalescence, and it has a shorter learning curve for the surgeon. And I think in the future we will continue to evolve less harmful procedures and techniques even further. Thank you for your attention.
Thank you. Now to round out the options for management of the T1A renal mass, we'll have Dr. Karim Bensala tell us about ablative techniques.
Thank you so much. My name is Karim Bensala, a urologist from France. I am very happy to be here, so thank you for the invitation. I'm very happy to talk about kidney cancer with esteemed colleagues. So my talk is about ablation techniques for localized renal cell carcinoma. So when you look at international recommendations, there are differences between the statement from the AU and the AUA. The AU recommends to offer thermal ablation to frail and comorbid patients with small renal masses and goes against radiofrequency ablation when the tumor is superior to 3 centimeters. Whereas the AUA says that thermal ablation can be considered as an alternate approach in all patients with T1A renal mass less than 3 centimeters. So why is there such a discrepancy? It might come from the low quality of the literature. If we look at the queries on PubMed on thermal ablation, you will find many articles, but most of them are not relying on high-level evidence. And when I was part of the European guidelines panel, I remember we were always discussing about which recommendation we should give on thermal ablation, and everybody was complaining about the low quality of the evidence and that we could use to support our recommendations. So we decided to make a systematic review, an extended systematic review, including all the systematic reviews that were available in the field. And we found around 26 articles. We only analyzed comparative studies that were comparing partial nephrectomy to thermal ablation. And here's the summary. These things were quite expected, but we found that most studies were retrospective, observational, with poorly matched control groups, very short follow-up, poorly described data. Very often there wasn't even a clearly identified primary objective. There was considerable heterogeneity in the methods used or in the way they were reported. And all of this made us conclude that current data were inadequate to make any strong conclusion regarding the clinical effectiveness of thermal ablation for the small renal masses. So that was a problem. So having said that, what can we keep in mind when we want to consider this thermal ablation? Well, in my opinion, the first warning that we should have in mind is that there have been reports of worse oncological outcomes with this thermal ablation. This is the largest clinical series that comes from the Mayo Clinic with Bradley Leibovich as a senior author. They compared more than 1,000 partial nephrectomy to around 200 patients who were treated with RFA and or cryoablation. And although they did not find any difference in terms of recurrence, they showed that there was a slight decrease in metastasis-free survival in the group of patients who received RFA. This is not a big difference, but it's worth being considered because we know that usually the outcomes are very good. And this was confirmed by other publications, including that one, this very recent one. This is a publication from the Karakevitz team. They queried the SEER database, more than 40,000 people who were treated for a small renal mass, and they did very fancy statistics, including propensity score matching, sensitivity analysis, matching patients who received partial thermal ablation to all the patients who had partial nephrectomy. And no matter how they looked at the data, they constantly found a worse cancer-specific survival in patients who were treated by thermal ablation, particularly when the tumors were larger than 3 centimeters. And this is also true for T1B tumors. This is the updated series of the Mayo Clinic 5 years later. This time, they didn't find any difference in terms of outcomes in T1A patients, but in the subset of patients who were treated by either partial nephrectomy or cryotherapy for a T1B tumor, they found a worse cancer-specific survival in the group of thermal ablation. And this has been also mentioned by other teams, including this recent publication by a team, an American team, again, querying the SEER database, more than 6,000 patients who were treated for a T1B tumor, and with, again, adequate propensity score matching, they found that cancer-specific mortality was significantly increased in the group of patients who were treated by cryotherapy. So this is the first thing to have in mind, that there might be a red flag regarding worse oncological outcomes, both for T1A and T1B patients. Thermal ablation was at the beginning competing with open partial nephrectomy. And my colleague just showed you that now things have changed and that most of the cases, at least in Europe and America, are done robotically. And there have been many improvements with this approach. And so nowadays, the two techniques doesn't compare in the same way as it used to be. This is a recent French multi-center comparison of patients who are treated by robotic partial nephrectomy and thermal ablation for both T1A and T1B tumor. You can see that here again, the oncological outcome are worse with thermal ablation. And when you look at the morbidity, there is still more complications and longer lengths of stay when patient received a robotic partial nephrectomy, but it's not that big a difference. And in fact, it all comes down to the natural evolution of these small renal masses, as Sarah beautifully showed you this morning. This is data from the DISSRM registry that shows you that, in fact, no matter what you do for the small renal tumors, you will achieve a very nice cancer-specific survival, whether patients are actively treated, receive primary treatment, or receive active surveillance. You have a worse overall survival, but this reflects the bias of selection of patients who are considered for active surveillance or thermal ablation. And there's also a point that has to be underlined. It's the definition of recurrence. There is no proper definition of recurrence after thermal ablation. We follow them with CT, with MRI, and there is no really strictly defined criteria on which we can rely to be sure that the tumor has been totally eradicated. And this holds true for the new techniques that are being published with the stereotactic ablative radiotherapy. This is a very recent, a very nice paper that's been published in European Urology, come from the group of UT Southwestern in Dallas. They did a phase 2 trial, including 16 patients who were treated with stereotactic ablation, and they report a 94% local control at 1 year. But when you look at the definition of the local control, this is either the reduction in tumor growth rate or what they call pathologic evidence of tumor response. But when you look closely, the patients who had a biopsy at 1 year, the 12 patients out of 16, they all had viable residual tumor. Despite a low expression of Ki67, they still had those residual tumor cells. So it's very quite blur to talk about total tumor eradication. So to conclude, with all this low quality literature, we can say that thermal ablation is associated with long-term survival in single-arm, non-comparative studies. But it is not known whether such benefit is related to the treatment per se or to the natural evolution of these small tumors. There is some evidence of possible worse cancer-specific survival, particularly for tumor larger than 3 centimeters. So in the end, TA can be offered to treat small renal masses, but the patients should carefully be advised regarding the limitations of the evidence that we have. Thank you.
Wonderful, thank you. Now we're going to move on from T1A renal masses to get an update on neoadjuvant therapy from Dr. Grant Stewart.
Thank you, Brad. So it's a huge pleasure to be back here in Edinburgh, a place that I studied, worked and lived in for 20 years. Great to see friends and colleagues from my time here before moving to Cambridge. So thanks to the KCA for having the meeting here in this great city. So I'm going to talk about neoadjuvant therapy and give you an update. Here are some learning objectives for my talk. So of course we don't have neoadjuvant treatment in renal cancer, so why should we consider it as a strategy? So there have been phenomenal advances in the management of renal cancer, particularly over the last 10 years, particularly in metastatic disease. But let's have a look at this data slide that I quite like. So this is changes in age-standardized mortality rates for all cancers over the last 50 years. And if you concentrate on this column here, So for all cancer sites, there has been a 27% improvement in survival over the last 50 years. If we look at other urological cancers, for prostate cancer, we've done even better with a 39% improvement. Bladder cancer, a 27% improvement. But kidney cancer, only 4% improvement. Now, we can debate whether we agree with this data, whether it's the right data source, but I think the message is that comparatively, we've done less well than other tumor types. So why is that? Well, I would put it to you, we have done very well in the metastatic space, and we therefore can make some real changes to how we manage localized kidney cancer. So here's a list of possible ways we could do that, and clearly exploring the role of neoadjuvant treatment in renal cancer is one avenue that we should look at. So how might neoadjuvant treatment benefit our patients with kidney cancer? So it might provide a survival advantage with an enhanced efficacy of drugs with the primary tumor in place. It may well downstage the disease, making curative surgery more achievable. Of course, it should allow us to better understand the biology because we can obtain tissue before treatment, we can obtain tissue at nephrectomy after treatment, and during treatment we can take liquid samples. It may well prevent progression if there's delays in surgical treatment. So this is a live problem for me in my practice. We are very stretched in our National Health Service. It's now uncommon for patients to have surgery within the first month after seeing them in the clinic. It may allow treatment at the earliest opportunity. So after seeing the patient, whilst we're waiting for surgery, we are treating them. It could be more reliable than adjuvant treatment if local therapy and the recovery from it is challenging. It could provide a personal prognosis. So in breast cancer, a pathological complete response is tantamount to a cure. And finally, it may allow disease biology to declare itself, though extremely aggressive disease where surgery may not be the best option. What are the possible downsides for neoadjuvant treatment in renal cancer? Well, we could get progressive disease, missing the window of cure, and there is evidence from some of the melanoma trials that that may have happened. But does that indicate negative biology that's destined to relapse? There may well be toxicity that could delay surgery, be lifelong and life-changing. And knowing if the patient is responding is clearly very challenging. It's a black box. We don't know what's going on. So we need better surrogate markers of a response. So let's look at what's been done recently, notable recent trials. So starting with neoadjuvant TKI. And the trailblazers here were Jose Karam and our dear friend, the late Chris Woods, who undertook this study in neoadjuvant axitinib. So they subjected their patients to 12 weeks of this treatment. And you can see here that, well, you could see that 46% had a partial response to that drug treatment, with most of the response being by 7 weeks, with a little bit further deepening by the 12-week time point. It's actually that 7 to 8 week time point that I took into the next study, which was this study NAXIVAR that I led out of Cambridge and was also run in Edinburgh here, where we were looking to downstage the tumor thrombus so that we could aim to have a less morbid operation with a less risk of mortality from that. So in NAXIVAR, any patients with a tumor thrombus, be it in the renal vein only or in the IVC, were eligible. They could have M0 or M1 disease. They had to have clear cell disease, so they had an MRI at baseline, a biopsy for diagnosis and obviously for translational research, 8 weeks of axitinib based on that Jose Karam study, and then they had an MRI scan to assess the outcome of the drug and the downstaging before going on to surgery. And of course, we took translational liquid samples as we went through. And I just want to flag my colleague James Jones's poster that's here at the meeting where he is going to discuss some of our initial correlative data from NAXIVAR. So what did a good response look like? It looked like something like this. So on the left, we've got level 4 disease, where the disease is almost into the right atrium. And then after 9 or 8 weeks of axitinib, we see a reduction in length and a reduction in girth to below the hepatic veins, making the surgery less substantial. What were the endpoints? Well, the primary endpoint was a reduction in this so-called Mayo classification, which is an anatomical level, and reflects quite well on how we undertake the surgery. 35% of people had a response in terms of a clear reduction by one level or more. Critically, there were no progressors. Nobody progressed in terms of a Mayo level. 75% of people had a reduction of some degree in the level of the tumor thrombus. So what did we take away from that? Did we achieve our objectives? Well, we thought that we did. It was effective. 41% of patients had a reduction in the extent of surgery after the 8 weeks of drug. Was it safe? Well, toxicity was comparable to the previous studies. There was no evidence of increased morbidity or mortality at the time of surgery. Were there any disadvantages? Well, there was no clinically relevant progression. There were patients who didn't get to surgery. There were several reasons for this. Some of the metastatic patients did have metastatic disease that progressed, and potentially that was disease declaring itself that didn't warrant surgery. So we didn't see any huge negatives. But it's an outdated, single-agent TKI treatment, a single-arm study with no survival endpoints. So what about neoadjuvant checkpoint inhibitors? So there are 2 neoadjuvant nivolumab studies. None of the patients in these studies had a partial response. So I won't talk about that any further. But that led Axel Bex to develop the combination IO-TKI study NEO-AVAX, which was an open-label, single-arm, phase 2, 12-week study of avelumab and axitinib prior to nephrectomy in high-risk localized renal cancer patients. And this is what Axel saw. This has been presented in abstract form, and I know he's working on the correlative work and also some longer follow-up. Interestingly, 30% of the participants had a partial response, and you can see the sort of depth of response at each of the time points. So the conclusion was this was a safe approach, but why were we seeing better response rates, 46% partial response with that Karam study, than we did here? What's the IO component adding? Well, we hypothesize it's adding quite a lot, and that might be where we stimulate some survival advantage. So Axel's looking at correlatives there, and we'll bring in the correlatives from the NAXIVAS study, where we can look at what the differences are between IO, TKI, and TKI alone. I'll very briefly mention PROSPER. This was a large phase 3 study which had a neoadjuvant component, so it was randomization to neoadjuvant nivolumab, surgery, and then adjuvant nivolumab versus surgery alone. Again, this has only been presented in abstract form, but this is the data, the top-line data. The study was stopped early because of lack of efficacy by the DMC, and there was no difference in recurrence-free survival between the arms. There's quite a lot we still need to know about this study to understand the results better. But of course, kudos must go to Mohammed Alaf for undertaking a very large phase 3 study in the neoadjuvant into adjuvant space, and we're looking forward to the translational data to understand this a little bit more. So what about the future? So this is the current portfolio. So there are 11 clinical trials of neoadjuvant treatment in renal cancer on the portfolio. Mostly are phase 2. Only 2 are randomized, and none have survival endpoints. So this doesn't seem to be moving the dial dramatically. So I've been trying to get some inspiration from other cancer types about how we can try and do things better. And one platform that really has inspired me is the work in breast cancer, the I-SPY 2 platform run by Laura Esserman. And here they have, for the last 13 years, had this rolling platform of trials that have used early endpoints, pathological complete response, and adaptive design, so you modulate the number of people in each of the drug arms, real-world controls, biological targeting, a master protocol, serial imaging, and biomarker discovery. And this is what they've done. I mean, it's pretty impressive, the number of agents they've put through this. Different investigators lead each of the arms, which makes the community engage with this. And you can see that some of the drugs have graduated to later phase trials. Others have been halted and don't move on because there's no evidence that they should do. This can happen in renal cancer, and we in Cambridge have set up a trial called WIRE, the Window of Opportunity in Renal Cancer trial, which is being run in Cambridge and is going to be rolled out across a few centres in the UK, which is a mini version of that concept. So the first 3 arms of WIRE are based around olaparib treatment, and we've almost got to the end of those. We're coming to some further arms which are bispecific agents, which are quite exciting. we are using correlative biological endpoints, so imaging-based endpoints and molecular endpoints rather than survival, because it's such a short time frame. We're using a Bayesian adaptive design, rich translational sampling, and adding new arms is quite simple when we go back to the ethics committee. So just to close, can we learn from progress in other cancer types? I've shown you I think we can. Melanoma is another great example. They've developed surrogate endpoints. They use biomarker selection. They've coordinated trials that build on the previous art. They use national networks for delivery. And I would finish by saying I think the KCA is in a great place to try and help us to develop the community in order to deliver these complex trials. Thank you very much.
Thank you, Grant. We're going to move on to Dr. Axel Becks, helping us understand what is the risk of recurrence, how do we classify these patients, and what's the pathological background for that?
Yeah, thank you very much for the introduction. Good morning, everyone. When I got this title, I thought, it's not really up my street, but I think it's a very important one, because we have to go back to the basics, and if you look at recurrence classification systems and pathology, it was all summarized. But I think it is a very good topic leading up to the next presentation by Victor, which might also explain a little bit to us why we saw these differences in adjuvant trials, and it touches a bit on what Grant was just saying. So the learning objectives, from my point of view, were to describe the current classification systems we have, then recognize the differences in pathological subtypes, and also touch very briefly on the molecular things that are ongoing. We only have 11 minutes. So let's go right into the talk. Classically, the risk has always been assessed by TNM, and it's still being done by pharma. The reason is because it's much easier. We also have very good risk models like UISS and Leibovitz, for example. The Leibovitz score was created in 2003. And basically, I cannot go into detail for all these risk models we have, but what they do, they use clinically and readily available factors and piggyback them together with TNM. The UISS score, for example, also includes non-clear cell renal cell carcinoma, Leibovitz only clear cell. It has been updated. We'll touch on this in a minute. And they're really good. If you look at validation sets, for example, the area under the curve for the prediction of recurrence with Leibovitz is 0.84, so it means you're wrong in 16%. That's much better than the flip of a coin. It's even better than the IMDC or MSKCC criteria, and this is all based on clinical subsets only. Now, the reason why the pharmaceutical companies, when they design trials, are not so much interested in using them, if you look at the overview, for example, some trials have been performed with Leibovitz, like Rampart or SOURCE in the past. But it's simply because Furman grade was used to assess the risk in Leibovitz. You now have ISOP and WHO, so we do not know what that really affects the interpretation. Now, regarding subtypes, we, with the EU guidelines on a Blue Monday, decided, now there are no data about follow-up. Let's create our own data sets and comparators. So we had a prospective database collection on contemporary patients who undergo surgery in Europe. We have now collected 3,600 patients in there. Basically, it was meant, as I already said, to compare the frequency of imaging and the outcome and the type of imaging, but you can also play a little bit with that. And if you look at these data, and they're fairly recent, so they're all from the TKI era, you can see that clear cell renal cell carcinoma, there are other data sets, we are not the only one, is more aggressive than papillary. But you also see that, for example, the risk assessment by UISS, so that's the University of California, Los Angeles Integral Staging System. It's a mouthful, but UISS is easier. You can see that it does not distinguish that well between the intermediate and the low-risk groups. And that is also that there is an unmet need, shows it very clearly. We also see that there is a different pattern in recurrence. It's what we clinicians very often see in clinic, and we do know that. There's the preponderancy for clear cell to have the lung as a primary metastatic site, but in papillary renal cell carcinoma, you very often see that large tumors remain locally, and you find a couple of lymph nodes. And chromophobe, if they metastasize at all, so 5% of all chromophobes metastasize, they have a predilection, at least in our series, to go to the liver and the bone. Now, as already said, there is a need to improve risk scores. Tobias Klatte has spent a lot of time in this Venus score, which is an acronym for venous extension, nuclear grade, size, and stage. And again, here you can see in this slide that there is a slight improvement in comparison to the TNM system and other systems we already had. Now, we had an updated version of the Leibovitz score. Don't want to be too critical about this. I think it's very useful, but it's not used very commonly in practice. We've introduced it, for example, in London and where I work, but it's also because our pathologists deal with kidney cancer only. They use that score very frequently, but it gets a little bit complicated, and that is one of the reasons why. And I like this paper. I was involved there as an author. When the source data came out, we actually looked at a revalidation of the Leibovitz score on current data. I think it's a very important paper because it showed us two things. First of all, the Leibovitz score from 2003 is still valid. Don't forget that source included all kinds of subtypes, also non-clear cell, papillary, and chromophobes. It was also validated for these subtypes. It works well. You could see also we learned from there that in 2003, patients who had been at the low Leibovitz score are now at the intermediate risk, so actually that improves, and the lower risk is even lower than it was in 2003. We come to this in a minute, what this might be related to. But most importantly, what it shows us is that the predictive value of TNM, look at this, is 0.56. It's almost as close as a flip of a coin. So with these grading systems or staging systems, we believe we can identify patients with high risk. High risk is also not very common. Again, we used here, before these trials actually published, our data set from the Recur as a sort of hypothetical fixed population in Europe, and we said, well, if all these patients would make it into the trials, what would be the percentage? If you're too exclusive, for example, you can see that iMotion would only capture 16% of your European population undergoing surgery. But it also showed that in retrospective series, the inclusion of patients with N1, for example, or T4, which have the highest risk, is actually very, very low. And was almost spot on as the real series of the keynote here. You can see the overview of the patient data from the keynote trial. That's almost spot on, 6.3% N1, so with positive lymph nodes, and only 3% roughly who present with T4 disease. So high risk is not very common. And to make matters worse, we can really ask ourselves if contemporary PT3 has the same risk as in the past. I already alluded to, this is another paper here from Vasudev from the UK, where you can actually see this migration of the risk in the Leibovitz scoring system to lower risks nowadays. And one of the explanations might be that a lot of T1, clinical T1 tumors are being operated now laparoscopically or with a robot, partial nephrectomies, and then it turns out that they are PT3A. But they are not the PT3As of the classics. You know, and what you can see is that the disease-free survival or recurrence-free survival here in 5 years is a staggering almost 80% in this group. So if I just would like to remind you in the Everest trial, for example, that was just recently reported with everolimus, it took them about 4 interim analyses to actually see the events coming in. So that while they selected the same risk groups as in Assure, for example. So there's a huge mix out there, which we probably don't understand. So there's a need to go into biomarkers. I like this paper very much. It's from the TraceX group in London. And this is on metastatic patients, but they could show that certain driver mutations are present in the primary tumor, which then might be decisive for the fate of the patient. If you have this punctuated evolution type, then you're much more in for rapid disease progression. This may be one way of looking at it. I don't think that anyone has found the Holy Grail, but we should also not forget that 5 years ago already, we had a 16-gene CHIP score, which was validated in several adjuvant trials that have been performed in the TKI era. And look at this. This is the highest risk group by TNM in ASTRAC from the placebo arm, and how this 16-gene recurrence score separates them into low, intermediate, and high risk. So we really do not know what is out there when we include patients by TNM. With this, I would like to conclude. We got one of these standard slides, like take-home messages. I think for the practice, I would say use the validated clinical scores. They're better than TNM, certainly if you want to design your follow-up and the risk of progression. And I think in the future, we will definitely have to go for molecular risk assessment, also to assess the individual risk of a patient. We should not forget that 40 to 60% of our patients in adjuvant trials are probably never developing a recurrence. Thank you very much for your attention.
Thanks, Axel. So now we'll move on to results from adjuvant trials, how to select patients and what therapies are available from Dr. Grunwald.
Yeah, so we've heard a bit already about perioperative treatment, and so my role is now to get you through the adjuvant trials, which we performed in the past 2 decades or so. So first of all, thank you for the invitation to really speak about this exciting topic. And my part will be addressing basically some of the key data and really, how do you implement this in your clinical practice? And I think to start off the discussion is to have a case. And this is what we talk about. This is a patient having a T3A tumor, and I also picked it on purpose because I think this is the T3A business. As also Axel alluded, I think is really the most difficult one. No lymph nodes, R0 resection, of course. So what did we see in the past is really, with the inclusion of targeted therapies, really a whole set of different large phase 3 studies. Of them, most did not really succeed. They did not meet their primary endpoint. There's just one outlier, I would say, which is the ASTRAX study. But anyhow, none of these treatments are available in Europe, and it's for a reason. So something has changed a bit, I must say. So with the advent of immunoagents, we had really hoped that we could induce long-lasting effects, especially in localized disease. And these are 4 different studies that have been presented recently and changed our treatment landscape. And they do address, pembrolizumab, atezolizumab, nivo, and ipi-nivo as the immunocomponents, actually. The study designs are depicted here, and basically they're quite different. They're different on how they select patients. That's not that part I won't go into detail because I think it's a large discussion that you may have. And it's a duration of therapy, for instance, like Checkmate 914 has only 6 months of therapy, but therefore it has a combination. Prosper, for instance, that does not have a placebo control, which also makes things difficult when it comes to really events and how patients are being followed in these trials. And then there's also difference in terms of primary endpoints, which could be central review or investigator-based review. So there's a lot of things that are different that could influence outcome in these different trials. So I will start off with the one that is being positive, which is Keynote 564. It's licensed in Europe and other parts of the world, of course. And basically it had different populations, categories, put them into intermediate, into high risk, and also in patients that are resectable for metastatic disease that then had additive treatment postoperative after therapy. So all of them, irrespective of the risk group that you look into, you do see there is a benefit towards the experimental approach, which is the pembrolizumab 1-year treatment after resection of tumor or metastatic disease. And the effect size may vary a little bit depending on the different populations you look into. Something that as you have seen in the discussion beforehand, is really important. What we use is more TNM, although Axel, I think you really made it a little, it's not as accurate. Having a 0.56 C index for TNM is a bit disappointing, to be honest. Anyhow, that's what we use. We use T, we use N, we use M to grade our recommendations in the multidisciplinary teams. And I think it's a good exercise that Keynote 564 really came up with this additional setup to showing, what is the proportion of tumors that have been included, and the largest proportion is really T3 in those trials, especially in this one. And depending on the TNM grading, you see highlighted the different effect size. The good thing is, you do see treatment effects across all subgroups, but with a lower risk of recurrence, the effect size seems to be smaller than the ones that have a very high risk of recurrence. I think that's something that can be said from this analysis. Then something that we use more and more in clinic, I think, is looking into biological subgroups. One way to do it is use common morphology. So sarcomatoid RCC is not a WHO subtype, but it's a de-differentiation of common cancers, and sarcomatoid RCC, that should be sarcomatoid clear cell RCC. Actually, that's what we're looking at. And I think what you see is that once you have sarcomatoid tissue within the tumor, those patients do better with immunoagents. And I think that's something that we see across all the different data sets that we have in adjuvant trials, but also in metastatic disease. So that's also something to keep in mind, that there are different subgroups that may benefit in a different way from immunoagents. So do we ultimately really improve survival? I think that's the key question, and we cannot tell yet, I think, but because it's immature. But from Keynote 564, there's a clear signal indicating that there is a separation of the curves and the trending towards favorable outcome for pembrolizumab treatment. So I think, it's too early to draw definite conclusions, so we will have that discussion in a couple of years' time. But for now, it looks good, and we do see a signal. So what about the negative trade-offs of immunotherapy? And again, this is pembrolizumab, the licensed drug. So when you look into the lists that you see here, basically, there's nothing surprising. And the immunotoxicity that is associated with these type of therapies is very similar to what we see in the metastatic disease. But I think, it's not the numbers that are really important here. The question would be, what about long-term outcome? Because you could induce diabetes for lifetime in these patients. And remember, most of them are being cured. And what about neurological toxicity? It's very rare, but it may occur. What about cardiac toxicity? And it's different in the risk assessment in the adjuvant disease than it is in metastatic disease. And I think that's something we have to keep in mind, and we do need more information about this type of outcome in order to really counsel our patient correctly. So what about the other trials? And there are 3 different large trials that also investigated immunoagents, but they were not successful. Basically, I've put down together here some of the key aspects, like the TNM, like the size of the tumors, that differ a bit in type of their inclusion. And in PROSPER, as we've heard from Grant, they used one shot of nivolumab prior to resection, so that gives you a little bit of discrepancy in those patients that are being included based on a clinical assessment, and then afterwards in a pathological assessment. So there is a bit of discrepancy, of course, when you use this kind of setup. So basically, none of those trials really showed relevant disease-free survival impact. And one of the reasons, I think, is also the diversity of the patient cohorts, and also the patient populations have been included. It's the toxicity that is associated with specific therapies, such as ipi-nivo, for instance. The combination is more toxic. You have a higher rate of discontinuation, and therefore less treatment, basically. So, all those things, they contribute to the curves that you do see here. And the question is now really, how to counsel patients? What do we really tell our patients? And I think it has been mentioned before, it's really shared decision-making. And I think, therefore, the voice of the patient is quite important, because what we think is high or low risk of recurrence may be completely different from the patient's perspective. And I think this is a very good data set showing that the stress that is associated with the diagnosis of cancer in persons, it diminishes over time. This is what you see here on the very first curve. But the risk or fear of recurrence, it is maintained over a long period of time. And so recurrence is really meaningful to patients. And something that prevents recurrence is also important. And when you balance then basically the different effects, or when you ask patients, what is the most desirable effect, of course it's efficacy. You want to be cured in the localized disease. That's the main goal of the exercise. We're less keen about toxicity, and I totally understand this. So going back to the case, T3A and 0, G2. So what is the risk of recurrence? And I think that's something we have to deliver to patients in order to really balance it against the risks that you take. And I've put 3 different tools that you may use and find, and you've seen already a couple of them, the different exercises that you can take. And on the left-hand side is the UISS. Basically, it's TNM without necrosis. You find it a moderate risk. I don't know if you can read it, about 80%. 5-year overall survival. Then you can go up to sign. It will give you a different readout because it includes necrosis. And then I think the most contemporary section is really the one from Fox Chase because it uses contemporary data sets and it has more variables to type into, and that's what listed down here: age, size, histotype, grade, necrosis, end status, and so on. And it's probably the most, most current and contemporary predictor that you may use. So it's about 5 years disease-free survival probability of 45%. So take-home message. Basically, what we need to do is really to empower patients to make that decision. I think it's not easy. And we have to counsel patients about the risk of recurrence, but also about the risk of treatment, basically. And I think pembrolizumab can be offered to patients, and we have to really monitor for long-term outcomes and chronic toxicities because it's really important to make the decision and put into the type of data. Thank you very much.
Thank you. And our final speaker for this session, Dr. Arnaud Magin, is going to speak to us about cytoreductive nephrectomy for patients with metastatic disease.
So good morning, everyone. It's really my pleasure to be here. I would like to thank the organizing committee for inviting me today. This is a very important question. So there is 2 types of nephrectomy. The first one is made for patients with localized kidney cancer. And unfortunately, for some patients with bad evolution, we have to start a systemic therapy. The other situation, which is quite different, and very important to consider that, is a patient with a synchronous metastatic RCC. It's a very different situation, and for those, we have 2 options. The first one is to make a nephrectomy followed by a systemic therapy. It is a good definition of the upfront cytoreductive nephrectomy. And the others are patients starting by a systemic therapy, and then for those with a good evolution or a complete or a near complete response on metastatic sites, we can decide a deferred cytoreductive nephrectomy, which is in secondary nephrectomy. Interestingly, for the trials that lead to the approval of the drugs, there is a mix of these situations. Localized nephrectomy done for localized kidney cancer and patients with synchronous metastatic kidney. And there is a mix of the situations which contributes to introduce biases for the interpretation of the results. So today there is no randomized clinical trial on the era of immune checkpoint inhibitors, so we have to go back to the retrospective study. So on this slide I put the 10 retrospective study in blue, and I put the items which are, from my point of view, relevant. The year of the publications, the number of the patients, the type of the study. There is 6 cohort study, the number of patients with intermediate versus poor IMDC risk factor, the patients having a targeted therapy and those with immune checkpoint inhibitors, the patient with upfront cytoreductive nephrectomy and deferred cytoreductive nephrectomy, the total number of patients with cytoreductive nephrectomy and the total number of patients without. And here, the benefit, and you can see that 6 on the 10 of the 10 studies show a benefit in terms of overall survival for a patient with a cytoreductive nephrectomy. In green, you have the 2 randomized clinical trials that you know. The first one is Symposium, unfortunately negative, including 99 patients. But interestingly, the secondary endpoints show benefit for a patient with a deferred cytoreductive nephrectomy versus upfront. And the Carmela study, in the subgroup analysis, we show that patients with 1 risk factor and 1 metastatic site have a benefit of cytoreductive nephrectomy, and patients having a treatment with a very good response have definitely very good interest and significant improvement to have a deferred cytoreductive nephrectomy. So I know it's impossible to do that, but I do for you, because from a statistical point of view, it's wrong, but I do anyway. On this 10 retrospective study, the majority of patients have an intermediate versus poor. The majority have, don't have a cytoreductive nephrectomy. The majority have an upfront versus deferred. And the results are that the overall survival seems to have a benefit for a patient having a cytoreductive nephrectomy, but, and it's very important to consider that this benefit mostly concerns deferred cytoreductive nephrectomy, low IMDC risk factor, good performance status. This is the 2 randomized studies that you know. Interestingly, I would like to, and I use this audience to kill a message. When we present and published Carmela, there was a very wrong message saying that a lot of patients have a poor risk factor in the cohort of Carmela. It's absolutely wrong. And if I go back to the study, you can see here that a majority of the study have exactly the same repartition between intermediate and poor risk. So now you are the messenger to kill this message. Thank you very much. If you are looking to the historical IMDC study, and especially that one from Danny Eng, published in 2014, interestingly, the repartition between intermediate and poor is the same, but at this time, the repartition between patients with cytoreductive nephrectomy and without is different, meaning that probably there is a change of the paradigm of the study. So this meta-analysis was published showing the repartition and the effect of nephrectomy. And if you are looking to the PFS and the OS, the results is exactly the same. There is no benefit for patients with nephrectomy versus without. But again, interestingly, it is the study made in these trials. So with Axel Bess, with Axel, we published last year this paper, and we go back to the study to check the patient with the primary tumor during the introduction of the study. And you can see here there is a low number of patients with primary tumor in the study, but again, the odds ratio is favorable of patients with the study. So meaning that, again, there is a mix, so we have to be careful for interpretation of the role of nephrectomy in this series. So we have to wait the randomized clinical trial. The most important is probably the Nordic Sun, which compare Nivo-EP or TKI-IO plus deferred cytoreductive nephrectomy versus no surgery. The results is supposed to come in September 2026, including 400 patients. And the other is a very interesting study, the PROB trial, which compare patients with Nivo or double dose of Nivo or Pebro or Avelumab, based combination therapy with and without cytoreductive nephrectomy, and the results will coming in July 2033, including 364 patients. So what is the possibility to make a surgery after a treatment by immune checkpoint inhibitors? You remember at the beginning of this strategy, some series seems to show that it is very difficult to make surgery. Fortunately, there is 2 multi-center studies published a couple of weeks ago and a couple of days ago, meaning coming from very good centers, 75 patients in the first series, including patients from MDA, Memorial, etc. Another series including 113 patients coming from UCLA, Dallas, Fox Chase, Mayo, Just something, etc. So very good centers. The results are exactly the same. The majority of patients have had an open nephrectomy. The intraoperative complications were low. And the 90 days post-op complications were low. So meaning that the surgery is definitely possible after a strategy starting by ECI treatment. So this is what we learned from Kamena, and it is the last slide of my show. And I make exactly the extrapolation of this data, meaning that today, in April 2023, from my point of view, the strategy is roughly the same. For oligometastatic patients, and for patients with non-oligometastatic patients, but with an intermediate IMDC risk factor with 1 risk and 1 metastatic site, probably the best option today is to start by an upfront cytoreductive nephrectomy, plus or minus a local treatment of metastasis, plus or minus delayed systemic therapy, depending the number of metastases. And for patients with 2 risk factors or more than 1 metastatic site, probably the best option is to start by a systemic therapy, whatever is the systemic therapy. And for patients with a good response, according to the RECIST criteria, I mean the complete response or a partial response, probably the best option is to decide a deferred cytoreductive nephrectomy. Fortunately, for the patient with poor or for patient having a bad evolution, we have to go back to a second-line systemic therapy. So in conclusion, I think we have to wait, obviously, the phase 3. We have to distinguish when we are studying the literature, we have to distinguish between synchronous versus asynchronous metastatic kidney cancer. Post-immune checkpoint inhibitor surgery is definitely safe and possible and feasible. And until today, April 2023, I think we can extrapolate the results of Kamena in short time. And the conclusion of my conclusion is that the best treatment for metastatic RCC is to treat the primary tumor and the metastasis, but I don't know what is the best order, upfront or deferred. Thank you very much.
Thank you so much. We are short of time. We know that renal cancer is the silent killer. So I would like to ask the panelists, just say yes or no. So Axel, do you discuss all the patients on MDT because it's a really cornerstone?
Yes.
Anila?
Yes. Yes.
Yeah, everyone?
Yeah. Absolutely. Yeah.
Okay. And do you have all the different modalities for treatment at your institution? And if not, and you choose that the patient should have a nephron-sparing ablation therapy, do you then send the patients to another institution right away? Please answer, Axel.
Yes, we have the options available, but otherwise we would send them away. Yeah.
Yes, we have the options available as well.
Yes.
Yes, same for us. I mean,
We don't have SABRE, so we refer on. Obviously, we don't do bench dissections if that is ever required, so we refer on. I think it's a key question. We must, whichever centre, you give all the options and send the patient based on their decision-making to the best place to do that treatment for them.
I couldn't agree more. We have all the options, but absolutely, if we didn't have them, we would be
we're happy to refer. I think second opinions are really critical in terms of helping patients make the decisions that are appropriate for them and choose the optimal selection of the optimal therapy for them. And you have to present the data in a fair and unbiased fashion and help them make the decision that's right for them.
So it's really a place where we have to do better, some places at least. So MDT is also a cornerstone in treatment of the individual patient. So thank you to all the speakers for excellent talks, and thank you for the audience to listen to this surgical program. And remember to visit the sponsors and also to look at the posters. So Brad and I will close the session. Thank you so much.